I can't see if I'm sharing. Can they hear me? Hey, guys.
Hi.
I have the slides up, but I don't know. Okay. Do this, and then share first, right? Share my screen. Share. This. And then this. Can you see this screen?
Yes, we can.
Oh, exciting.
Okay, and Jane, whenever you're ready.
Fantastic. Thank you all. Sorry, we're having a wee bit of technical difficulty here. But thank you all for joining us. The title of this webinar is The Intersection of Housing and Employment for Clients with Incarceration Histories. Next slide. Marina will give us some instructions for this conference call and using Zoom now.
Hi, everyone. So just some rules for this. This webinar will be recorded. We will be saving things. We are going to mute during the webinar, and if you have any questions, please use the Q&A at the bottom of the screen. You can type in your questions there and address them specifically for them to be asked to. If you have any technical difficulties, please use the chat box on the right side of the webinar. Next slide, please.
Thanks, Marina. Again, thank you all for joining us. I'm Jane Fox. I'm the co-PI of the Evaluation and Technical Assistance Provider for this HIV Housing and Employment Project. This webinar is one of many in a series that we will be conducting this year and next to help support all the work that you do on this initiative. Next slide. So today we'll be hearing from 3 speakers. These are our learning objectives. First, we wanted to talk about policies and practices to consider. We'll talk about the intersection of correctional health and public health. And then we'll also discuss the impact on communities and program interventions. Next slide. So before we get started, the incarceration and the U.S. justice system are vast. They're complicated topics. There's many facets and subtopics, most of which we won't even attempt to address today. So today you will get kind of a high-level, shaving off the top overview of information. But during year 2, we will convene some dedicated space to discussing the topics of incarceration and housing and employment. And we'll provide technical assistance for sites that are working with reentry populations. As many of you know, and you will see through these slides, both racism and injustice are very much linked to policing and incarceration. So we recommend kind of separate, comprehensive anti-racism and social justice training when you're working with this population. You will see those themes, and we are acknowledging that, that this exists and that this is also an opportunity to gain some other skills and trainings around these topics. Next slide. So today you're going to hear from, as I said, 3 presenters. 2 I have worked with in the past, kind of 2 of my favorite people out in the world outside of what we're doing here in these initiatives. You'll hear from Allison Jordan, and you will also hear from Jackie Cruzado Quinones. Both of them have experience Allie currently working at Rikers Island. Jackie recently retired, but I'm sure that much of her experience is quite fresh. And she has a lot to say and share on these topics. The third presenter, Cynthia Tucker, is the Vice President of Prevention and Community Partnerships at AIDS Foundation Chicago, one of our ETAP, or our project grantees. And let me just note, we love being able to use our grantees in sharing their experiences and training other grantees and intervention staff on what they excel at. So we are thrilled to have Cynthia joining us today. So I'm going to turn it over to, I believe, Allison and or Jackie to start us off with some background on policies and practices to consider.
Thank you so much, Jane. Right back at you. It's Allie and Jackie here. I'm just going to go through a little bit of background to give us a level playing field a little bit about the topic areas that we're going to go through, and we look forward to having further conversations with you all about your populations and how they may be impacted by the justice system. One thing just to keep in mind, that the U.S. spends more money on healthcare than on social care than on healthcare than social care, unlike most other countries. And in terms of, when you think about the expenditures of the proportion of our money that we pay on, just butter versus guns, the majority of it is not going to social care. Much more of it is going to the healthcare system. So just think about that as we go forward and the implications for it. Back in the 40s, 50s, and 60s, there were more people in psychiatric facilities. They closed. Community mental health did not expand as promised, and the incarceration rate grew to meet and then exceed the population that was in psychiatric facilities then. So we're really talking about four basic populations of folks when we talk about the correctional population. So there's people in your community who are on parole and probation, and there's people who are behind bars in jails and prisons. Jails being a place where folks who don't have bail will wind up, and we'll talk a little bit more about what the different, where these folks might actually be seen. But as you can see, the U.S., this is, I think, part of how we decide to spend our money as a country. We have over 700 folks out of 100,000 who are incarcerated, and you can see how we compare to the rest of the world. And so why are people involved in the justice system? They may be arrested on charges awaiting disposition. They could be innocent till proven guilty. Fees and bail bond fees and risk being fired from their jobs that will lead them to have unemployment issues or be unable to pay their rent. They could have a history of arrest or incarceration and not be able to live in areas that they can afford to live in. They may be under community supervision with very specific conditions that fly in the face of what an employer might want or what is needed for the family. Competing, compelling priorities. So about the U.S., of course, not all of our sites are average, and indeed, one of the states, as part of this initiative, has almost 1% of its population incarcerated at any given time, and the site with the state that has the lowest incarceration rates is still 3 times that of the United Kingdom. So, Jackie, you want to talk a little bit about the pie?
Yeah, thank you. Thank you, Ali. Yeah, so I wanted to show this pie because I think it's very important for us to see it. And I want us to think about a pizza pie. So this pizza pie has 6 slices. So think about 2 of those slices are actually people who are incarcerated behind bars. And then 4 of the slices are people that are actually out in the community, either on parole or probation. So, how many will your intervention actually touch? So in this slide, we want talk about what is part of the community correctional setting. Who's part of this community correctional setting? So you have people in psychiatric treatment facilities, you have community residential treatment facilities, halfway houses, 3-quarters. You also have prison wards. And so this list actually shows exactly who is part of the community setting. So, how many people in the United States? This slide is really people that are locked up in the United States. So this actually represents the 2 slides that we were talking about in the first pie. And 95% of the population that are incarcerated will return to the community. What are correctional facilities? Who is in these facilities? You have local jails, you have day release programs, you got prisons. Let's not forget the federal detention centers or the federal prisons, immigration, youth detention. I mean, this is a list of what actually you could see that correctional facilities are at. So how did we get here, Ali?
So we've gotten here as a nation because of minority health disparities, of how we handle poverty, and for what happens to folks when they're so isolated in correctional facilities that become a forgotten part of our communities, but the impacts are real. And so you'll see that Latinos and Blacks are overrepresented, whites are underrepresented based on the population that is arrested. You would expect to see potentially more people, but it's about poverty, and remember the inability to pay bail, and also policing practices. But consider in your community health, safety, and justice policies, incarceration of young men of color. They say, you know, folks that are arrested for turnstile jumping are never going to stop turnstile jumping. So what are we doing? You know, a Metro card would solve the problem, but we spend a lot of money outside of that. So we do know that there are programs that can be implemented. There's great examples all over the world, including in Norway, but programs to divert people from jail to community programs, facilitating alternatives to incarceration. You could have a health liaison that works from the inside out to the providers in the community. Employment services and housing supports are a big key, and one of the reasons we thought it was so important for you guys to hear about this, and to also remember that the family supports are a problem. So the health disparities among the incarcerated compared to the general population are tremendously higher among the people who are incarcerated, and likely aligned with what you would see in your community, in your highest needs community, the communities with the highest socioeconomic status. And so think about also frameworks that can help you think about this or receive training in it. We teach folks who work with the incarcerated about dual loyalty, how you feel aligned with the correction folks, but the reality is that you're a health provider first. And then the transitional care coordination model, which we'll just spend a nanosecond on, has helped to address this and to provide linkages to care as well as maintenance and care, the stickiness that we're looking for through these interventions. So this is one example, the New York system, where we demonstrated that the people coming home after incarceration, that's the rates in the yellow bubbles, in fact are very aligned with both HIV diagnoses as well as socioeconomic status. So the reality is that if you want a smart way to go about looking for the folks who are at greatest risk in your community, it is likely the people that are newly admitted to jail that are among the population that you're looking to serve. This is the model we created. We're happy to talk more about this, just in terms of having systems be integrated through this transitional care coordination model. And the outcomes that we found were substantially able to get people linked to primary care after incarceration. But this slide here on the clinical and survival outcomes, we call it the money slide, the pitch slide, because it does show that, in fact, the things that the transitional care coordination health outcomes demonstrated, in fact, saved money in your community. So the average emergency department visits per person went down by 0.4 on average, and The homelessness and hunger went down by a substantial amount. Look at that, 20 to 23% homeless and hungry on jail admission, and less than 5% in the 6 months after incarceration. And that's in the New York City model. You can see similar rates of reduction in other areas where they did not necessarily have the same infrastructure that we had, but similar rates of reduction. So people who are involved with the justice system come from communities with the greatest socioeconomic disparities and have the most needs related to social determinants of health that this initiative is all about. They're very likely to have histories of foster care system involvement, be unstably housed, reside in high rates of poverty, and benefit from these interventions that we're sharing with you to sustain HIV care and treatment after incarceration. And here's documentation that we have that shows, that HIV diagnosis is pretty even across the board between those who, on the average, the people coming into the incarceration system during and after release. But then you have tremendous drops of linkages to care, retention in care, initiation on heart, and then undetectable viral load in folks who actual care and treatment has been disrupted by virtue of being returned to the community without a safety net. Similarly, if folks aren't linked to care in the first 2 weeks after incarceration, the likelihood of viral load suppression declines precipitously right after that first 2-week period. So we know that the social impact after incarceration includes loss of housing, all your belongings, getting evicted, not knowing if you might have folks who are in prison for a long time. They may need special job training. They may not have ever had a computer. There's a good number of folks who have kids involved in the child protective services, especially the women. The stigma of incarceration coupled with the need to gain employment, not just for sustenance and survival, but also for parole and probation, creates significant, compelling priorities that people can't really manage both. There's all kinds of conflicts there. And not just the incarcerated, but the families are also fighting legal issues, having phone charges, fees. There's all kinds of ways that our systems are designed to take money from folks who don't really have enough to feed themselves. And so when you look at the challenges at the nexus of correctional health and public health, you're looking at homelessness, substance use, mental illness, chronic disease, lack of continuity of care, and very significant mortality rates in the first 2 weeks after incarceration from the east in New York and to the west in Washington State, mortality rates in the first 2 weeks incarceration, primarily due to overdose, but also stressors that really relate to cardio issues are impacting people after incarceration. So mass incarceration, housing instability, and HIV are all embedded with one another. They dovetail, and housing is, of course, one of the probably the most important factor in terming health outcomes. We know that with housing comes food, with food comes the ability to manage getting your medication and those kinds of things. So what we're looking for from this intervention and to support you all with is to design and develop programs that will help improve continuity of care, housing, and employment. We know that folks who are behind bars are going to return to the community, and we want to see if we can help support your jurisdiction in having the needed resources in the community. We know that 14% of all HIV patients in the U.S. spend time in jail and prison. Incarceration does not occur in a vacuum, and that we know that there's poor outcomes for infectious disease, and that community ties, families are definitely a facilitator. Children of incarcerated parents, this is powerful. So we'll have community support folks. They need help reuniting with family. They need financial assistance. They need microloans. Do they have barriers to employment or a limited history? And how might the workforce development work, especially rental assistance and rehousing? Is someone on a fixed income because of disabilities? So many folks coming home out of prison are old now. They've served 2 years, 15, 20 kids when they went in, and now they come out and the world is different, and they have not involved with the kind of things that are available in the community. They may just not know how to access housing vouchers or Section 8 or whatever might be available in your community. And then mental disorders. The traumatic brain injury among this population is something like 2 or 3 times higher than football players. Very high. So in terms of who are seeking because they're too sick to stay back on them, or they'll come to jail to really a place that's warm or cold, depending on our medical respite programs. There are community alternatives, and there are possible ways of engaging people while they're very well informed. We have ways of helping you to identify and focusing on how you utilize the system. Doing this to provide tips regarding employment, try to get ID documentation from corrections very often. Employers will, or parole will need police. They won't take any word for it. So there are documents that you relationships with or and after incarceration, we've done peer educator training, like the peer-to-peer model within the jail. So businesses that have hired people with histories of incarceration is something that some of our community partners do, like the Fortune Society
and Puerto Rico One Stop.
And Puerto Rico One Stop. And then also, once those employers have hired people with histories, they can mentor others. So Jane, I don't know if you were able to set this up, but we do have a poll, and 10, let's see, there's 20 topic areas. There you go. So the first 10 topic areas that you can vote for. So most in learning more about. So we have aging and incarceration, case studies. Jackie's got a bunch of case studies. The culture of corrections, community engagement, employment services. There's health homes as part of the Affordable Care Act that we've worked with, hotspotting, housing, and those kinds of things. So for the first 10, if you let's close. And the next one now. There you go. Oh, thank you so much, you guys. This is awesome. Readiness and from reentry to reintegration. Thank you so much. Motivational interviewing. We find that SP part more than the end of expert particularly helpful. Trauma-informed care and all that we do, substance use, transportation, so many places. Without transportation, you're really in all kinds of trouble, especially if you're in an isolated area. So we'll just take a second for your vote. And then we're going to get ready for Cynthia. There you go. Trauma-informed care, awesome. By far, yeah. And then, can we see the women? Yeah, and women also 50%. So our next presenter is Cynthia, and we're going to, I guess I'm going to stop sharing. Is that possible?
Good afternoon, everyone. This is Cynthia from the AIDS Foundation of Chicago. I'm so excited to present our program, the Safe and Sound Return Partnership. So I'm just going to kind of give a really high-level overview and describe our Safe and Sound Return Partnership program that really dovetails with what Allison presented talk about our intensive case management program, which is the foundation, our client referrals for how we are recruiting and getting individuals into the program, talk about our housing, employment, and just a little bit about evaluation. So our initiative and goals are to connect 215 individuals to healthcare, employment, and housing services over the 3-year program through the use of our peer community re-engagement specialists. We also want to increase the capacity for a better provider system for those individuals that are working with the reentry population. And then lastly, we want to convene or have convened a multi-sector coalition that includes the Department of Labor and AIDS housing providers. So to be a part of the program, there needs to be 3 criteria that are met. They have to be recently released from jail or prison, 18 years old or older, and HIV positive. So before I get into talking a little bit more about the program, I just wanted to give you a real landscape of. Currently, we have about 50,000 individuals that Illinois Department of Correction, part of our Cook County chair. We have about 500 people being released per day. Adult transition centers. Our the HIV population comes in prison is about 4 times higher than general population. Our corrections case management for the Safe and Sound Return Partnership. We have the comprehensive system of intensive case management for HIV reentry to connect individuals to care, employment, IDs, and other services, recidivism, and serving this population. And we have committed case managers that I have pictures of. Our target male, 8 per 6, that has and 1 to 2% transgender, mostly males between 18 and 29, before being an average age without representation. And key stakeholders, I really want to emphasize the task force, media and marketing, to me, communication, working with training the community. Different project components, the peer community re-engagement specialists, our corrections case managers, which are dispersed throughout Chicago and Illinois, and our task force partners. So just to give you a sense of how we are connected, our 2 community re-engagement specialists are located at Austin Health Center and Core Center and Christian Community Health Center in Chicago, and they work to recruit individuals into the program. This is just a listing. I wanted to make sure that you had the idea that this is a partnership and a collaboration of organizations who provide unique services for the reentry population to come together to build strategies for decreasing the social determinants of health of this population. This slide shows our recruitment, which, as you can see, we have to do several steps to get individuals in, get them consented, and the follow-up at 6 and 12 months. This is a form that we created so that we could track individuals from the time that they signed their consent form and are eligible to the program, and making sure they go through the 12-month assessment. It is a guide so that we can keep track and make sure that we are within our 12-month, 6-month deadlines to get them into housing and employment. So our Safe and Sound Return Partnership strategy is three-pronged, working at the client, provider, and systems level to decrease the social determinants of health. So our client level is really to expand access to health care, employment, and housing services, one, by connecting individuals to our corrections case managers. Two, at the provider level, we want to provide capacity and build training. So we are developing and have delivered so far 6 trainings on undoing racism, cultural responsiveness, trauma-informed care, and HIV confidentiality. And then at the systems level, so our multi-sector task force with over 30 organizations with our HOPWA and Department of Labor organizations are coming together to create our structural interventions. So our employment. So we have several steps from employment preparedness to job placement. And so what we have done is we have stepped out that process to make sure that individuals, once they are released, get into the correct path to make sure that they're on their way to employment. We have several goals, which means that we are establishing new linkages to employment-related opportunity and businesses, creating transitional jobs through our current organizations, and working with several programs that are currently working to hire reentry participants. So if you look, this is a chart that really developed the steps. So we knew that when individuals are released that they may not be ready even for employment readiness. So we wanted to make sure that we had steps that will assist them to getting to there, working with several organizations to make sure that they can get into job placement as quick as possible, using internships, using different gateways for employment. So we passed that out. So just so you know, we kind of created an acuity score. So when an individual is released, our navigators work with them to do an employment assessment, and then they are put into a certain level, and then that certain level really describes their path and how they will get to employment. So we know that when individuals are released, they have a myriad of issues and challenges, including mental health, substance use. So we want to make sure that they are able to stay into recovery. So we have transitional housing, supportive housing, and permanent, as well as housing and rental assistance as a part of our program. Then we stepped out the housing program just to make sure that we can get them into the correct path. So we did the same as we did with employment. I didn't put a slide on the different levels, but it really looks the same, making sure that we can work with a myriad of housing programs across the state, from transitional to permanent housing. Our evaluation plan includes a lot of process, making sure that we're having all of the consent forms completed, working very closely with ETAP, doing all of our program forms, doing baseline at 6 and 12 months, doing our training and making sure that we are looking at the impact of those trainings through pre and post-test trainings, and then conducting qualitative interviews. We're using our Provide Enterprise database system to do our corrections case management program to make sure we're keeping up with the viral loads, all of the information. And then we're using Client Track to track all of their housing. And of course, we're using REDCap and our ETAP evaluation monitoring system, and then Tableau to really kind of design our programs and our dashboards and making sure that we have really rich data. Our staffing resources include a variety of individuals across the AIDS Foundation of Chicago, as well as inclusive as our task force partners.
Okay, everyone. So if you have any questions, please use the Q&A, which you can get to by hovering your mouse to the bottom of your screen on the black bar. If you have a specific question for Allie, Jackie, or Cynthia, please say who it's for. If not, please just let us know if you have a general question. And I see in the chat, Nikkei said, what tools are you using for your acuity score? I don't know if that was directed towards Cynthia, but Cynthia, is that something you can answer?
Yes. So we created our own tool. We based off of several that we found to put something together that was really specific to this population.
Awesome. Okay. Does anyone have any questions? If you can't find the Q&A box, you can type them in the chat as well. So we also want to know, Allie and Jackie want to know, which training would you as participants on the webinar, which one would you like to see first? And you can type that in the chat box. So if you guys can't remember, some of the things that we have listed in the poll were human rights and dual loyalty, mental health and mindfulness, motivational interviewing, networks and collaboratives, substance use, overdose prevention, and naloxone distribution, morbidity and mortality after incarceration, transportation assistance and accompaniment, trauma-informed care after incarceration, visitor family outreach and engagement, women in incarceration. Some other topics were aging and incarceration, case studies, community re-engagement, culture of corrections, employment services and readiness, from reentry to reintegration, health liaisons to court, housing with case management and other supports, and hotspotters and your communities. So if you guys are interested in seeing one of those really soon, please comment. And please feel free to submit any questions.
Hi everyone, it's Jessica. Marina's asked me to give you guys a couple of prompts. Just curious about what parts of trauma-informed care are you all interested in hearing more about? So what are some of the specifics of your needs around trauma-informed care? You can put those in either the question box, the Q&A box, or in the chat box.
Okay, and we also got a question. It is, when we meet with different companies for possible employment for our clients, are we disclosing their medical HIV status? And we heard from Cynthia and Allie, no, not without consent.
Do you want to say more about that to our panelists? Do any of you want to say a little more about that?
I can. In Chicago, we do not disclose the HIV status of individuals unless they come to us and request that, and more than likely not. Most people want to keep that and not disclose unless they did themselves on their application.
Yeah, we would not disclose to a future employer someone's HIV status. We do have, through our housing and services and an entity that only works for the positive clients to make sure that they're stably housed, or Department of Social Services, but that's always done with the client's consent, and so you want to be very careful not to inadvertently disclose status by virtue of your program, your signage, your logos. We try to have staff see clients who are both living with HIV and at risk, so that no one knows whether our clients are living with HIV or not.
Allie, this is Jane. Can you talk a little bit more about that? I think that's the main concern, is by virtue of a clinic's name or a program's name. So how do you mask some of those things? What's the script or the dialogue that you use to make sure that you're not disclosing someone's status?
Right. So folks have health concerns, and that includes people who have chronic diseases and who may be at risk of disease, including HIV, so that we try to merge our CDC testing together with our HIV continuity of care program, so that to the outside world it's kind of invisible. And even if your signage says, we serve HIV positive clients, you say, well, we're also though trying to identify people who are living with HIV, and we provide health care and services to people regardless, because of the way our funding is. And so you just you want to find a way to make sure that you're not when we started in the jails, there was a door and it had HIV and a positive and a plus sign on the door, and then someone behind there counseling folks. So you want to avoid that, right? And instead now it's it's HIV services or chronic diseases, and she's also the person that does HIV testing as well as seeing folks who are living with HIV. So really, and know that employers that it really even comes up when you're talking about employment services and job training. I don't know if that helps.
Awesome, thank you. And we also have a question from the comments, a lot of different things that you could comment on to all of the panelists. So it says, how to improve awareness among staff in what trauma-informed care is, what it looks like, how to ensure you're providing this, and increasing awareness about the trauma that clients have experienced in bringing with them. Also, any trauma-informed screenings or checklists, and how to increase awareness of the importance of this across systems. So do any of the panelists have anything to comment on regarding those questions?
There's some very good trainings out there on trauma-informed care. I think applying it to this population and really just understanding how prevalent traumatic brain injury is among our population, not to mention we're going to ask about sexual assault and even microaggressions, women who are unstably housed because they're living with someone who is maybe not taking care of them. We found women actually having a no effect in terms of social support. We think because the hand that feeds you is feeding you, and so those kinds of issues are prevalent in the population. And just be aware that the settings that folks are in, if they've been incarcerated, are not women fuzzy favors. Anything else?
And just to add to that, I would suggest also one of the things that has been very helpful for us is that we have worked with individuals from the population to be a part of the training, because what they can share is very different, and that has seemed to resonate with all of our providers.
Awesome, thank you. Does anyone have any other questions that they can type in either the chat box or the Q&A box that our panelists can answer? So we do have a comment also from Janet Myers. Thank you for that. It says that HRSA is testing some trauma-informed care interventions through the E2I initiative, and that there might be more to come. So thank you, Janet, for letting us know. And then so Sarah asked if we'll be sharing the PowerPoint for all of those graphs. Yes, we will be sharing the PowerPoint so that you can take a longer look at all of those graphs and that information, especially some of the information about your areas locally, your local jurisdictions.
Yeah, we can talk almost by county what the incarceration rate to help you with hot spotting and looking at folks coming out after incarceration. There's some cool tools out there that Vera Institute has on their website if you want to play as a preview. But yeah, you can see you can see for yourself where the areas are that you should be targeting for likely your poverty and HIV and housing needs and employment services are folks coming from the same communities. Yeah.
So I have a question for the panelists. When we were doing a rehearsal, a dry run of this presentation last week, what we talked about was we felt concerned that perhaps there were we would dip too far into talking about racism and poverty and other injustices that lead to over-policing and incarceration of certain communities, particularly communities of color. So we wanted to probably scale that back a little tiny bit. But one of the things that we talked about during a rehearsal was that it's incredibly important to have anti-racism training and emphasis on the anti-racism piece of a social justice training as well. So in asking a little bit more about that, I was asking Cynthia what kind of work they had done at AIDS Foundation Chicago, because as she mentioned in her presentation, they've been at this for a very long time. So Cynthia, I'm wondering if I can ask you, and then Allie and Jackie also, if you guys want to chime in after, what is, how long of a process is it? Is it a kind of a Zen process, the process to nowhere? It's iterative, it continues. Can you just describe your experience, Cynthia, in trying to bring an organization forward on anti-racist practice?
Yeah, it's been a long process. So we have been working on this for the last 2 years internally at the organization, and we have created several committees to work to bring trainings and education to our staff. And then we've been working within the Safe and Sound Return Partnership to work with the task force to bring a variety of trainings, as it's important. You have to have an understanding of the participants that you're working with to be able to serve them. And so we've been working with a variety of trainers, including the People's Institute, from New Orleans to come in and do trainings and education. We've had a variety of individuals come in to talk about trauma-informed care and really the connection to mass incarceration and what has been happening for Black and brown individuals. And so that we can raise the awareness, have an understanding of their challenges, once they are part of a reentry population, how we can best serve them.
Great, thank you. And Allie and Jackie, I see that you put a resource up, but do you want to speak at all to some of your experiences?
So, I mean, Jackie says, you know, begin where your client is, and so it's not just your client could be your employers, right? And it could be your cities, and it could be your government, and it could be your systems. And so I think there's a lot of work that's being done on this nationally through the American Public Health Association. They have an anti-racism collaborative that you can join without being a member. It's based out of Cambridge, and I like Dr. Kamara Jones' Gardener's Tale as an article to take a look at the difference between the red flowers that the gardener likes and the pink ones that he didn't, and try to get folks to think about even with our correction officers. They'll say, oh, I grew up in the same communities, and very often they'll be reflective of the same population that we're working with, but something different happened to them. And so I'll ask them, so who helped you? And someone. And so if you can get to think about it, if they're reason, you know, oh, well, you know, people should pull themselves up by their bootstraps, and like, oh, listen, boots, right? So if you go, and Jackie was really awesome at this, joke around with them and say, oh, yeah, is that right? And did you eat or did you not eat? And so talking with people on an individual level, working with programs, and then also looking at the systems level, the training, so that, you know, having a progressive mayor is certainly, you know, a thing, you know, that the facilitator, but, you know, it doesn't have to be that way. It's all and just helping people to see how much money we're investing in a system that we know doesn't work, and that keeps people from being taxpayers. And so, yeah, begin where the client is, right?
Mm-hmm.
Awesome. Thank you so much, guys. That was a great webinar and really informative. Just so you guys know, coming up, we do have another webinar for our TA series. But in the meantime, if you guys want to contact Allie, Jackie, or Cynthia, then you can do so by emailing them at the provided email addresses. And as mentioned, you will be getting copies of these slides. So if you don't have time to jot them down now, don't worry about it. Our upcoming webinar will be on field safety. This will be on October 16th at 1 p.m. Eastern time for an hour and a half, as our other webinars are. And thank you for joining us today, and we look forward to talking with you in the future. Thanks, everyone. Bye.
Bye.